Hello, everyone. Thank you for joining us today for this Lung Cancers Today roundtable. We'll be talking about optimizing perioperative and neoadjuvant immunotherapy strategies in resectable non-small cell lung cancer. I'm Dr. Ticiana Leal. I'm a medical thoracic oncologist and associate professor director of the thoracic program at the Emory University School of Medicine in Atlanta, Georgia. And I'm joined here by esteemed colleagues and panelists. I'll let them introduce themselves. I'll start with Dr. Antonoff.
Hi, my name is Mara Antonoff. I'm an associate professor of thoracic and cardiovascular surgery at MD Anderson Cancer Center in Houston, Texas. Thank you so much for having me here today.
Excellent. Dr. Merritt.
I'm Robert Merritt. I'm a thoracic surgeon at Ohio State and the James Cancer Center. I'm the director of thoracic surgery. Thank you for the invitation to be a part of the panel today.
Excellent. And Dr. Olazagasti.
Hi, yes, my name is Olazagasti, and I'm an assistant professor at the University of Miami, and I specialize in thoracic oncology and also head and neck. I'm a medical oncologist.
Excellent. So let's start talking about initial screening and diagnostic process for patients with lung cancer. And I think focusing here on lung cancer screening, not only the considerations, but also the challenges. I'll start asking you your opinion on sort of how lung cancer screening has helped in terms of stage shift and how you view the multidisciplinary team in the lung cancer screening process.
Sure. So, lung cancer screening is a very important part of early detection for lung cancer. I think some of the current challenges is the lack of awareness of the criteria, the eligibility criteria by primary care physicians, who primarily are the main referrers of patients who meet criteria for lung cancer screening. So as a result, a very low percentage of eligible patients are actually getting screened. But the good news is that there are two randomized clinical trials which demonstrate a decrease in lung cancer-related death in patients who are screened for lung cancer. So with that in mind, I think it's a very essential part of early detection. One of the other challenges is, if you do pick up abnormal lung nodules, I think it requires multiple disciplinary input from thoracic surgeons, pulmonologists, and also primary care physicians to decide which lesions require biopsy and which ones require follow-up and additional scans. So I think those are some of the inherent challenges in lung cancer screening.
I'd echo what you said, Robert, and just to add, I think there are some additional challenges beyond that. Certainly NLST and Nelson both showed significant increases in early detection with low-dose screening and mortality reduction, but this is in patients who were already felt to be at higher risk, and so these are patients who are at-risk populations who are being screened, and so we kind of have two separate challenges that lie in the fact that number one, uptake is still a barrier. So in underserved populations, patients still might not be getting screened, even if they should be. And so that's a challenge that we deal with in patients who do meet those criteria, being increased risk for lung cancer based on their age or their smoking history. But then the other issue we have is that we're seeing more and more patients who don't qualify for lung cancer screening because they're non-smokers or they're particularly young. And in those patients, they still continue to present with advanced stage disease. So clearly, while we know there's an important role for lung cancer screening and it's allowing us to find more of the patients at an earlier stage, we recognize that there are substantial limitations to using this type of imaging study in patients who are just deemed to be at risk. Certainly, there's room as we develop more screening strategies to hopefully eventually develop blood-based biomarkers and other ways to incorporate algorithms that will help us identify patients at earlier stage in populations who may not be easy to get to a CT scanner or who may not even be considered for screening.
Yeah, good point. And in terms of getting a positive screen, and I know that can mean different things, how do you coordinate that? And how do you deal with the pathways and process, and importantly, the patient communication in getting those results and sort of the next steps for patients?
That's a great question. So at my institution, we use the Lung-RADS scoring scale. So patients with 4A or 4B lesions which are deemed to be high risk for lung cancer. We have a consultation discussing, the options in terms of biopsy versus, continued surveillance. The 4B patients, which are the highest risk, we do counsel patients that, biopsy would probably be a better option. And then that discussion is, the risk benefits of, the biopsies, the different techniques for biopsy. And then if there is a lung cancer detected, then the discussion is, what are the best therapeutic options? So it does require quite a bit of patient communication and sometimes some multiple disciplinary input from our pulmonary colleagues who often perform a lot of the biopsy procedures to diagnose lung cancer.
Excellent.